Hear me okay? Excellent, thank you. So my name's Michael Richardson, and I'm Deputy Chief Nurse at Bristol, North Somerset, and South Gloucestershire Integrated Care Board. Quite a mouthful. I was meant to be here also with Sarah Jones, who is the Director of Nursing for Avon and Wiltshire Partnership NHS Trust, but last-minute diary urgent commitments meant it was just me. But I'd also like to thank Catherine Lupton from NHS England, who's helped us put the slides together. So I've got about 9 slides to go through with you, and it's about developing a quality early warning system tool in collaboration with different system providers and also NHS England and commissioners as well. So to start with, I think what's really important just to say is, as a Deputy Chief Nurse, I noticed that the Deputy Director of Nursing for South East Region was dancing up and down with data. Now, I'm not going to be doing that this afternoon, but one thing I do need to say is that I very much have been quite a data geek over the years, since probably the early 1990s, when, as part of my nursing career, I decided to go into public health, and I did a master's in medical statistics and public health, and from that time, I have always been really into data, to the point that I've quite often annoyed my colleagues. Now, why am I telling you this? Well, partly because I remember a quote during my training from an epidemiologist, and he said, and he was quoting a famous epidemiologist, and the quote is, and some of you may know it, "Information in itself is useless and should only be tolerated if it serves a purpose." It was such a memorable quote, one that I use all the time, and in fact so memorable I cannot remember who actually said it. I don't know if it was a he or a she, a they or them. All I do know is I've remembered it over the years, to the point I'm now wondering whether I either dreamt it or even made it up. But it's a good quote. "Information in itself is useless and should be only tolerated if it serves a purpose." And I will come back to that saying at the end, because I think there's a little bit of a moral to this story that I want to try and tell in the next 10 minutes or so. So I'm just going to look at my karaoke screen here. It's a little bit easier than looking back. So this is really very much about a story about how we can co-produce an analytical and tool which is meaningful and iterative to others in a way that can be used to actually aid decision-making and look for early warning signs in systems or providers. Now, we're going to cover the framework, the tool. I'll go into that briefly, and then about how we've used different ways of working and conversations and collaboration with different parties to actually co-produce this tool. And then at the end, what difference this can make and how we can actually spread the learning. So this isn't a particularly new tool. It's like I said, it's been a bit of an iterative process, and our colleagues at NHS England and other colleagues across the country have been putting this framework together for some time, but it's been based upon a Scottish tool developed by Healthcare Improvement Scotland. And what NHS England has done is they've updated the framework to include National Quality Board guidance and also the CQC's well-led framework. So it is quite a long, comprehensive tool of questions, which I'll show you in a moment. And it's designed, like I said, to support integrated care systems, NHSE, providers, and CQC to actually identify, diagnose, and respond to early signals that there could be perhaps problems or issues that need to be looked at within a healthcare system. Now, you can see there on the top right, it's just a little bit of the actual tool, and I'll show you a little bit more of that in detail on the next slide. But what the framework does is it summarises main areas of concern and signs that should be considered, and the main sort of intelligence and data that we should be reviewing. Now, we back this up by, and many of you will be very familiar with the model health system, or the model hospital as its precursor was. And many of the actual signs within this early warning system are actually backed up by data through the model health system, and that's structured in there. And you can see an example in the bottom right of one of the actual pages, and that's the quality early warning signs for certain areas. And this framework is being piloted at the moment in 4 sites across the UK: South Yorkshire, Buckinghamshire, Oxfordshire and Berkshire, Devon, and ourselves in Bristol, North Somerset and South Gloucestershire. And there's a pilot working group where we all meet and discuss some of the issues. So if I can just show you an example of some of the questions. So there are 12 key areas for the actual framework. You can see those on the left. Some of those, I won't read them all out, but you can see strategy, leadership, risk management, governance, quality, finance and workforce. And this is the bit that's quite important to look at, is if you see on the right-hand side there, you can see the warning signs. So these are just some of the examples of some of the questions. There are far more, as you could see from the previous slide. So, for example, for leadership, and note that these questions are based in a negative way, and there's a reason for that, because these are warning signs, early warning signs. So for leadership, for example, we've got inexperienced leadership team, high increasing turnover rate of staff, limited clinical quality voice at the board, lack of scrutiny from non-executive directors. And then again, for governance, no clear accountability of governance framework for quality. Seems quite negative when you see it like that. And as I showed you on the other one, you can see there's far more questions than the ones I've just shown you. And these are the actual sections here. And as I said, there's 12 of these, and there's just 4 there. So you can see it's quite a comprehensive framework of early warning signals that we're going to be looking at. And the key lines of inquiry in terms of the pilot approach is basically to see how this is going to help us with the baseline of information that we've already got for providers, in terms of then collating the extra signs and data from this framework in terms of impact, and then how we would then use it in terms of making decisions that are helpful for the system and also for the provider. So we've used a real live example, and that is where we have worked together with a local mental health provider, Avon and Wiltshire Partnership Trust. So ourselves, the ICB, a neighbouring ICB in the area as well, which also commissions work from AWP, and also a South West mental health provider collaborative, NHS England, and the Trust AWP, we basically all got together for a few days and thought we would actually pilot this early warning tool. And it was really, really helpful. And the reason we were doing it was because AWP had reached out asking for support, because there had been some concerns that had been raised within the Trust through freedom to speak up, so particularly in terms of use of restrictive interventions, safeguarding, staffing levels, and also incidents. Up to that point, we'd already done some diagnostic work. We'd been working with the Trust, and we had what we call quality improvement groups set up. So we were working together to actually address a lot of these problems. But we thought it's going to be really important, particularly as a lot of these problems were sort of based around culture, that we needed to see if there's anything that we'd missed. And we thought, well, how are we going to do that? And how are we going to do that with a structure? Which is where NHS England came in and supported us and said, we're developing this new quality early warning signs tool. Would you like to pilot it with yourselves? So we said yes, and the Trust was really keen to do that. So hence, we all got together and did this work, and then actually worked through those questions that I just shared with you earlier. We'll make sure that you get a full set of that tool and also these slides as well. And there's a link to the model health system and the quality early warning signs framework within that set of slides as well. So how did it go? Well, first of all, the first thing, which was, I think is quite important, we had like I said, done a lot of diagnostic work up to that date, looking at a lot of the freedom to speak up issues that have been raised and the safeguarding issues. And so the first thing is the tool didn't actually identify any further areas of concern. But that was actually quite good, because that's what we felt, but we needed to have that validated through a separate sort of independent tool. So that was helpful. And it also gave us some structure to do those deep dives to make sure that we hadn't missed anything. What it also did was give us a clear, shared understanding of areas of concern, because we all did it together. It wasn't a commissioner doing this work and then saying to a provider, look, you need to improve. It wasn't the provider asking us for help. It was basically all of us working together, because we recognized this wasn't a provider problem. This was a system problem. Now, one of the things that was very interesting is that you would have seen earlier that there were quite a lot of negative statements. And the reason for that is because it is an early warning framework. However, you can imagine that whilst we're working through that, through the days, at times that got perhaps a little bit dispiriting, particularly when the trust is actually a really brilliant trust doing really well, but there have just been these concerns that we've been working through. And again, we'll go back to those statements shortly. And some of them we also found were, as we were actually going through the statements and looking at the early warning signs, we realized then there were extra statements that we wanted to add to it. So hence, don't be a slave to the statements. We did feel that we could adapt. Now, the reason I'm just going to go back again to those, the way, because it was written in a negative way, while that was really, really important for us to actually diagnose where the early warning problems were, you can imagine when we then translate that to a paper for people who are not familiar with the tool, that some things can be lost in translation. So, for example, if I go back to this one, what we did, you see, we rated every single question. So let's go back to, say, leadership. And you can see on the second bullet point down, it says, high increasing turnover rate. So for the provider in this particular case, they didn't have a high turnover rate. They had a very good, low turnover rate of staff. So we rated this as green. So you can imagine then when that goes to a board paper for non-executives and they see that it's green, they're saying, oh, but you've got a high increasing turnover rate. Yeah, you put that green. So there was a bit of a loss in translation there. And one of the things that we learned from that was, well, for a diagnostic tool, it's good to use negative statements. When you're actually then producing a report at the end, it's probably a good idea to turn all those negative statements round to positive statements, because then your red, amber, and green makes more sense. Because if it says low turnover rate and you've got a red RAG rating, then people understand immediately what that means. So if it's a green RAG rating, people understand exactly what it means. So that was a key bit of learning that we felt was important. So going back to some more learning from the pilot. So I think for us, the key area for this was actually being able to actually work on a live issue, made it really, really helpful, and helped us to structure it so that we were absolutely certain that we were not missing any data at all. Many of the early warning signs and symptoms, however, were sort of related to culture, leadership, and governance, and as a result, were a little bit difficult to quantify, because this was actually just looking about the sort of general culture within the organisation, whereas other areas such as finance and performance were very, very easy to quantify. So it was a real mix of qualitative and quantitative information, which again made it, whilst it was a challenge, also then made that quite a positive as well, made it quite rich. Because this was a live scenario, I think it required, certainly reflecting about it now, quite a lot of trust by all parties. We had three sets of commissioners in a local provider, and we were really getting under the surface, really getting under the skin about the issues that were going on within that organisation. And thankfully, these were just pockets of issues which we found, but we didn't know that when we started. So having that trust of all parties, and particularly the provider, I think was really, really important. And that's where, I guess, data analytics, epidemiology, commissioning, information, you can't do any of this unless you've got the trust of all parties and that engagement and that bridge building. And that's where, I guess, where the human factors sort of come in. We started testing this pilot with our local provider probably quite late within the time that we were actually doing work with them. And I do also think if we perhaps used this framework about a year before, had it been available, then we may have diagnosed some of the problems earlier, which would have been absolutely amazing. But just to conclude, so I did say at the beginning about that phrase that information in itself is useless and should only be tolerated if it serves a purpose. Well, I was thinking about Anita Charlesworth's excellent keynote speech this morning. And Anita said, data needs to tell a story. Data needs to tell a story. Well, I mean, I think this tool with further refinement, it does need some further refinement, but I think we're nearly there. I think with that refinement, this tool probably has the potential to tell a very accurate story. And it's just that way of actually putting all this excellent work in terms of data that health analysts and other colleagues do together in a structure that people like me who don't know how to do the detail can understand and make those decisions. So I wanted to change that phrase that I've been quoting for years now, whose source I've completely and utterly forgotten. I want to change the phrase to something else, and that is, information in itself is priceless when it tells an accurate story to empower decision making. And I think this tool is going to do that, and I think we're nearly there. So thanks for listening.
Thank you, Michael, for a wonderful talk. So we now have 5 minutes for Q&A. I've got some coming through on the Slido, or you can stick your hand up in a moment. So let's first of all take a look at the Slido. So Rupert asks, are there any examples or case studies where poor quality outcomes in trusts would have been identified by these early warning systems?
I think for us, and I can only use our own experience, we did find that when we actually used this scoring system, we didn't actually find any new problems. And I think that's partly because had we used the scoring system about a year before, we would have had a different structure doing it. Now that we have it, I think we'll start to grow examples quite quickly. We've got the 3 other ICBs who are working with their system providers. So I think we'll start to see later on this year some more examples. I personally don't know of any. Thinking about looking at the different scoring mechanisms within it, like I said, there's 12 different paradigms there of different areas. And I certainly know from our own system that if we'd have used this scoring system, we probably would have picked up quite well on some of the performance issues a bit earlier in other providers. I'm not referring to AWP. We would have also picked up on a lot of the good stuff that's happening as well in a different way. And that's what's been so brilliant about working with AWP as a trust, because they have been absolutely amazing and have been open to us using something which, let's be honest, hasn't been tested yet. So this was like probably one of the first, if not the first, live testings of this tool in the current way. So I haven't got any other concrete examples, but I think we'll see a lot more later this year.
Thank you very much. And talking of the different scores that you've got there, someone has asked on the Slido if any weightings were applied to the different measures, and if so, how they were decided. So
I think that is a brilliant question, and that is probably one of the areas that still hasn't been developed, because the only rating that we had was a RAG rating for each statement. So So green, amber and red. And we had those ratings for all of them. And we did not weight any particular question more than the other. And the idea was that once we'd RAG rated everything, you'd see an area, perhaps an area of red or an area of amber, which would be the focus of attention that we needed to go on. And that's the challenge, is how quantitative do you make it and how qualitative? Like I said, a lot of the information that backed up those statements is available in the model health system through all the excellent work that's going on in data analytics, etc. But some of it isn't as well. And to rate a qualitative statement more than a quantitative, or the other way around, I think has been a challenge. And maybe it doesn't need to be rated, because that perhaps would deflect from what the main purpose is. And I think the main purpose of the tool is to help everyone to talk together properly and to try and tell that story.
Thank you very much. And a final question from Catherine on the chat. Oh, no, another one's just come in. How long did the process take, Catherine asks. And is this something that needs to be kind of repeated on a regular basis, or is just one-off okay?
In terms of the process of developing the tool, that is still underway. That is an iterative process. And the learning from this live example is going to be used to refine the tool even more. In terms of the live example in Bristol, North Somerset and South Gloucestershire, process took probably, we spent 2 whole days in the trust working with our provider colleagues to go through all the statements. We spent probably a couple of weeks before those 2 days just checking in with each other that we're happy to use the tool. And then we probably spent about 2 or 3 weeks after that putting the reports together. And then from there, distilling into reports that other readerships would understand, which was, again, like I said, where we had some of those challenges in terms of turning those statements around from negative to positive ones. So, yeah, several weeks, I guess, for the live example.
Thank you. Is there any questions in the room? Okay, going over.
Yeah, I don't seem to be able to get my internet to work in this building, so this is the easiest way to do it. Hi, I'm a chief analyst at Nottinghamshire ICB. Just wondering, this feels to me like a really good approach to sort of try things at a local level and then feed back into NHS England nationally, so that there's sort of that testing locally before something is then rolled out nationally. That seems a very sensible approach, so that's good. I'm just wondering, in terms of sort of the metrics that you used, were they all things that were sort of available from the national data source already? And were there any metrics that you identified during the process that you thought where there were gaps in those national data sets, and was there sort of an ability to feed back that into the national teams to consider filling some of those gaps sort of as part of the national data collections?
Thank you. That's a really good question, actually. I think a lot of the information was available on the model health system, and it's been really helpful that NHS England have categorised the model health system within those 12 domains that I was sharing earlier. So that was really helpful. Some of the more qualitative statements around culture, that information we could only get locally from Freedom to Speak Up, events and incidents, and some of it was even anecdotal. A key area where we thought needed to be included in the tool, which isn't at the moment, and where we do have a paucity of information, is safeguarding information. And I think we need to get perhaps we need to try and work more with our local authorities to get that to feed in. So for me, it would be safeguarding information. That should be the priority. But that and perhaps seeing if we can perhaps just refine some of the qualitative statements as well.
Thank you. Okay, so we've got one more on Slido, and I'm going to leave the final question to the room. So online, this is quite a good question, actually. Do you think it's harder to have productive conversations about poor measures of culture with providers versus other performance metrics?
Wow, that's a $10 million question, isn't it, really? I think I would refer to what I was saying earlier about it's very much to do about having trust and mutual trust, and you can only build that up over having good relationships across your local system, whether that's providers, commissioners, local authorities. And this is where the work of health informatics and health and care informatics is just absolutely crucial, and goes to what I was saying, I guess, right at the beginning, because to me, if you haven't got the data, and if you've not got it in a way that tells that story, like Anita Charlesworth said this morning, then you can't have those conversations, which is why the work that you do is absolutely invaluable and needs to be absolutely at the forefront, because I can't have those bridge building conversations with providers unless I've got the data. But the specific question about culture, I think, again, if you've built up that trust over the months, over the years, then you can have those open conversations. Most of us who work in ICBs or other commission bodies have probably worked in providers at some point, and vice versa. So I like to see us all as one health and care family, really, and I know that might sound a bit motherhood and apple pie, but I do mean that. I do think we have to work as one family in one system, and by having those constructive conversations, we can do that. It's a shame Sarah couldn't be here today. She really wanted to be, and like I said, working with AWP has been absolutely invaluable, and a real privilege, I have to say. She probably could have answered that question better than me, but I'd like to think that she would have said that we can have those conversations because we have that mutual trust.
Fantastic answer to a fantastic question. Any last questions in the room, right at the back? This is getting the steps in.
It's a long room.
Hi, thank you. Tom Turner, South East Coast Ambulance Service. I was wondering if you've thought about integrating the language of making data count with sort of a wider quality framework. I know certainly with our internal integrated quality reporting, it's something that we've been using, trying to do a very similar sort of thing to this, identifying our internal problems in the same way you're trying to identify problems over a wider area. And it's provided a really useful tool for effective storytelling, for turning and making sure people focus on the right issues at the right time rather than over-responding to the wrong. And I was wondering if that's something you thought about integrating with QEWS?
And it's called Making Data Count. Is it? Yeah. Yeah, I'll take that back to the NHS England team. I think that's something perhaps we should look at in the pilot group and consider. I think if we can triangulate as much stuff as possible, then that's got to be good, really. So thank you for that. As far as I know, we haven't considered that, but we'll take that back. Thank you.
Okay, that brings us to the end of this session. Thank you again, Michael, for some fantastic questions and answers and a lovely presentation. I think we're now at a break. So, yeah, tea and coffee awaits.